Thank you very much, Maureen, and indeed Chris, for the very kind invitation. And it's a real privilege to be here and talking with you. So, as Maureen said, I've been involved with the UK MDS patient group for a number of years now, and it's been really fulfilling to see how successful it has been, how it's grown, and now it's able to help and touch every part of the UK. I've spoken at a similar Scottish meeting back in 2012 in Edinburgh during the British Society of Haematology, but the numbers were relatively small at that meeting. So it's great that we've so many people that have joined and hopefully are getting benefit from the group. So we're going to go through a few slides. A lot of this I would hope that you know, but it forms the basis for questions. And I know from my clinical practice that every single interaction with the patient, no matter how many times I've seen them, leads to a question of some form or another. So there are no bad questions. So there are only good questions. So feel free to ask anything you like. So I've decided to talk about low-risk MDS, and the main reason for that is that 2/3 of all patients that we see in MDS clinics have low-risk disease, but it tends maybe not to be focused on as much because obviously perhaps the acute need for higher-risk MDS is more obvious. And the greater link between higher risk MDS and acute myeloid leukemia makes the focus quite commonly on high risk MDS, but low risk MDS is becoming increasingly important and increasingly looked at in terms of decision making and treatments. So. No, I don't seem to be moving on. There we go. So I think a good starting point is what is MDS in general. So it's called myelodysplastic syndromes, and we're going to look at a very interesting slide in a while at the new classification systems and what that might mean. But there is general agreement now that all types of MDS are malignancies, and I hope none of you are upset by that and have appreciated that already. There has been debate as to whether for a long time as to whether low-risk MDS should really be classed as a malignancy, and indeed often patients with low-risk MDS don't manifest the features of cancer that we all tend to associate with cancer. But cancer is a biological disorder in which the normal control of cells has been lost, has been subverted, has been changed. And that occurs because of changes in the genes in those cells. And MDS has all of those features of abnormal function, changed function, and abnormal genes within the bone marrow stem cell. So this is a malignancy arising from the bone marrow stem cell. And the changes that occur in those MDS stem cells lead to ineffective blood cell production. And the reason that probably most of you ended up seeing your doctor and then a haematologist was that you had underproduction of one form of blood cell or another. The term dysplasia is like lots of the terms we use in haematology, is an old term, and often for that reason is difficult to understand and interpret. Indeed, the term leukemia is about 160 years old as a word, and was first used by a physician called John Hughes Bennett in Edinburgh in the middle of the 19th century, and it purely describes white blood, because that's what they could observe. The increase in white blood cells made the blood look white rather than red, hence leukemia. Dysplasia is similarly an old term that just means funny appearance, funny shapes and sizes of cells. So myeloid dysplasia means funny shaped myeloid cells, funny shaped bone marrow cells. As we've said, most people with MDS present with low blood counts, but that's very variable. And we see some people with very mild abnormalities and other people with very severe abnormalities. And of course, we have to face up to the fact that all patients with MDS have an increased risk of developing acute myeloid leukemia or AML, but that varies dramatically across the types of MDS. So the other thing you'll all be known about is often talked about is that MDS is a disease of elderly people. And this nice curve from 30 years ago now, it was the first time that this was really shown very clearly by Williamson et al. Shows the number of cases of MDS per 100,000 of the population of the y-axis against the age blocks in 5-year increments. And you can see that while MDS does very rarely occur in childhood, it doesn't really get going until the middle years, and the peak incidence is over the age of 70. And I think that is very important because it means that the majority of patients with MDS are elderly, and the issues that come with delivering healthcare in older people apply very much to MDS. Whereas again, an awful lot of the focus, understandably, is quite often on younger patients, mainly because you know, the disease has more of a long-term impact on younger patients, and especially because stem cell transplantation or bone marrow transplantation is focused on younger people, though the age range of bone marrow transplantation is of course going up, and there are patients in their 60s and indeed early 70s who have bone marrow transplant now, if it's appropriate. But it's a disease of elderly people, and we mustn't lose sight of that. So you can't hear from a haematologist without seeing some haematology. And I don't know if any of you have ever had the chance to look at your own blood film or bone marrow. So these are some slides that were taken in our department. So this is a normal bone marrow, and the thing to take note of, don't worry what all the different splodges are. Each of them are different cells. The thing to focus on is they're all different. They're all of different types, and that's what you see in a healthy bone marrow. They're all different types, and the blood cells grow up from these stem cells, which are the parent cells. And they divide many millions of times a day in order to produce these blood cells. And the stem cells are able to produce blood cells of all different types. And we have a term for that called pluripotent stem cells. I'd also point out to you these little clusters of tiny cells. These are the platelets. And in this blood film, they've all stuck together. But over on the left, I don't know if you can see my pointer, probably not. You'll see a little one in the left bottom hand corner on its own, and how small it is. But this is a mixture of red cells and white cells in a normal bone marrow. And if you look at this is a high resolution film of somebody with low risk MDS, and you can see the very distorted nuclear outline. So this is a dysplasia. And in the red arrows, we can see these abnormal white cells with nuclei, the dark purple that is dividing abnormally. And then on the black arrow, you can see a red cell. You can tell it's a red cell because the cytoplasm, the around the edge bit, is a pinky red. But this is an abnormal red cell. It's too big for the state of its nucleus. It's got a mature nucleus, but it's got immature cytoplasm. So it's too big, and you can see a nodule coming off the nucleus. So this is abnormal nuclear division and abnormal nuclear morphology. So these are nice examples of dysplasia. And I have a couple of more for you. So here are some more. So the red arrow up on the right is a giant platelet. We saw that little platelet. Well, look at this thing here. This is absolutely massive. So this is completely inappropriate platelet production. Over here is a giant neutrophil that has abnormal lobulation of its nucleus and no granules in its cytoplasm, in the grey cytoplasm. And that's, you'll have heard the term hypogranular neutrophil. And then up here in the top left-hand corner are, I suppose, the cell that causes the most concern. These are blast cells. So they're very immature cells. They have a very large nucleus and very little cytoplasm. And when we look at this nucleus, it looks immature. It's got this lacy appearance to it. And these, at least two of these three cells would be blast cells. And then finally, let's look at the megakaryocytes. These are the cells that make the platelets. And some of you will have low platelets because the megakaryocytes are dysplastic and not working. So this is a normal megakaryocyte. It's a very big cell compared to the other little white cells. And it's got this lobulated nucleus, but the lobules should all stick together in a normal megakaryocyte. And what happens to be this fluffy big cytoplasm breaks off and breaks off little platelets, which are dropped into blood vessels. So that's how the megakaryocyte makes platelets. And here is an absolute classic MDS, the so-called 5q minus syndrome. And you can see the platelet here, it's very abnormal and is very, very unique in MDS in a way. So you have these monolobulated megakaryocytes. You do see them in other types of MDS, not that unique, but very typical of 5q minus. And here is, we all have 2 of each chromosomes, and here are 2 chromosome 5s, but you can see one has lost this N bit of it. And this is the so-called long arm. There's a short arm and a long arm to every chromosome. The little kink is there is the short arm, and beyond it is the long arm, the Q arm. The short arm is the P arm, and in del5q, you've lost all this genetic material. And of course, we know a vast amount about the science of this. And it's that genetic abnormality that leads to the dysplasia and all of the other problems. So you can see that these are genetic abnormalities, but they're a question that I'm very commonly asked, understandably, when we talk about genetics in the clinic is this something I can pass on? And the answer here is no. So these are not inherited genetic abnormalities. These are acquired genetic abnormalities. They're acquired by the bone marrow stem cells as part of the MDS process, if that makes sense. So that's what MDS is. So we divide it kind of into low risk and high risk, but what is low risk MDS? Well, I think it's all of these things. It's not very formally defined, but I think it's all of these things. So it's a low risk of progressing to leukemia. And there's some very nice new data. I'm going to talk about the European Union MDS register that I've been involved with for 14 years now. And there's been a great research tool for understanding low risk MDS. And the register has just published some data within the last month of more than 2,000 patients with low risk MDS across the whole of Europe, looking at the complications of low-risk MDS, and because it's important to know these things, why patients with low-risk MDS die. Overall, the risk of progressing to leukemia in that very big cohort, so many different types of low-risk MDS, but they were all low-risk MDS, is about 20% overall. And we can come back to those data if you want. So, but compared to high risk MDS, that's a low risk of progressing to leukemia. So in keeping with that, the patients with low risk MDS have low blast counts. And we'll talk a little bit about blast counts later in the new classification. But at the moment, a low blast count is really below 5%. Between 5 and 10%, that is still MDS, and some of those patients can still be treated as low risk MDS. Certainly, once you get above 10% blasts, that is now high risk MDS. We have these fancy prognostic scores, and you may well know your prognostic score. We've had a number of them over the years. It started in the mid-1980s when two great MDS doctors and researchers, one was very well established at the time, and one was starting out, but is now extremely well established. The established one is the late Professor Terry Hamlin, who was I had the privilege to know and work with, and his sidekick at the time was a very young Professor Ghulam Mufti, who we all know now as the great Professor Mufti. And the two of them, together with other colleagues in Bournemouth, produced the Bournemouth score, which was the first prognostic score and very useful. But things have progressed since then, and now we've had a number of scores. So the first one on the left was the International Prognostic Scoring System, and we used that for a long time, and that still is used because this is what NICE and the Scottish Medicines Consortium used for deciding whether people with high-risk MDS were suitable for azacitidine. Okay, so in our MDT, in our multidisciplinary meeting, we still record the IPSS, though really for all clinical trial work and for most new trials, we've moved on to the IPSSR. So the International Prognostic Scoring System revised. And this was a more accurate scoring system. And that's really the current scoring system. And that's why I've got it in red. It's a bit more sophisticated. But in this scoring system, low risk MDS is somebody with a score of 3.5 or less. If you have a score of more than 3.5, you're not considered low risk. And then the new kid on the block from this year is the IPSS-M, where the M stands for molecular. And this reflects the growing understanding of the importance of identifying abnormal genes in patients with MDS. And we can now recognize a lot of abnormal genes that contribute to the MDS process, and different genetic abnormalities affect the prognosis in different ways. So we've now got the IPSS molecular. It's only just starting to be used, but I think over the next few years, we'll see it come to dominate prognostic scoring, especially in clinical trials. And the great thing is that there's an online calculator, and indeed there'll be an app which doctors can use and share the results with you. And then finally, overall, people with low risk MDS have a relatively good prognosis, and that's very important to recognize. So all of these things relate to low risk MDS. Now, this is what has caused the most excitement in the MDS and indeed the AML world over the summer. And I've been involved in several meetings and conversations and meetings. So really, for as long as I've been a senior haematologist, a consultant, we've used the classification system produced by the World Health Organization, the WHO. This is used around the world. And the WHO produced its most up-to-date classification of MDS and of acute leukemia, and indeed of all blood cancers over the summer. And this is usually a very big event. And once again, it's a very big event. However, for complicated reasons that we don't need to go into now for the sake of time, a different classification system has also been produced over the summer, again by a group of very worthy experts, and they've called themselves the International Consensus Classification. There are probably more clinicians in the ICC classification and more pathologists in the WHO. But the reason this came about was largely political, unfortunately. But we're left with two classifications at the moment. I'm just going to show you a couple of things highlighted in red, which I think are of interest and which might come up. So for the first time, the WHO has written down and confirmed that MDS are malignant diseases. So they've changed the name from myelodysplastic syndrome to myelodysplastic neoplasms. And neoplasm is the medical term for cancer. Now, this follows on from another group of diseases that some of you might have heard about, called myeloproliferative neoplasms. Now, they were originally called myeloproliferative disease, and some doctors still use that term, but the WHO changed it to myeloproliferative neoplasm back in 2016. And so they're doing the same with myelodysplastic syndrome. The thing that'll make you laugh is that with myeloproliferative neoplasms, they changed the abbreviation to MPN from MPD. So they changed myeloproliferative disease to myeloproliferative neoplasm and changed the abbreviation. With MDS, they decided not to do that. So they've kept the abbreviation MDS, but MDS now stands for myelodysplastic neoplasm. And don't shoot the messenger. There was much hilarity at the Scottish haematology meeting when we discussed this 2 weekends ago. So maybe MDS is too embedded a term to feel they could change it. Now, the next thing below that, you'll see that there is a move in all of these diseases to redefine MDS in terms of the genetic abnormalities. This is why the genetic abnormalities are so important. And I'll just point out one of the three here. You'll see MDS with low blasts and SF3B1 mutation. Now, in the past, this would have been MDS with ring sideroblasts. And some of you may well have that diagnosis. So as I come towards the end of my career, as you can tell, we're entering a stage where the term ring sideroblast is not mentioned in the classification. There are some rare situations where you can use that term, but for most patients, the term ring sideroblast will not be linked to their diagnosis, even though they have ring sideroblasts. So that's a big change. So there's a genetic basis to some of the diagnoses. However, the WHO have stuck with low blasts and increased blasts, but they've changed the term from excess blast to increased blast. So you see they've shown MDS with low blasts and MDS with increased blasts. And the key thing here is they've kept the increased blast 1 if the blasts are 5 to 9%, as we said, and increased blast 2, 10 to 19%. Now, the ICC have done something very dramatic. Okay, and they've decided that the important cutoff occurs at 10% blast. So at the moment, if you have more than 20% blast, you develop acute myeloid leukemia. Now, of course, in the past that used to be 30% blast, so it has changed. And now the ICC have decided that over 10% blast should be considered a new entity called MDS/AML. Now, this is controversial and has been much discussed. It's been done for very honourable reasons, I think. The ICC explain that they want the classification to represent the natural history and biology of the disease. And we do recognise that MDS and AML in many patients is a continuum of the same disease. It's a progression of the same disease, and they're not separate diseases. Secondly, they want patients with MDS to get, or some patients with MDS, where appropriate, to get treatment within AML trials, and vice versa. So they want trials to be agnostic in terms of whether you have MDS or AML if you have more than 10% blast. Now, we've been very good in the UK at doing that. So our NCRI trials in AML have included patients with MDS. And when I was the chairman of the MDS clinical trials group for 5 years, I made sure that happened and that indeed the inclusion was widened a bit. But in other countries, in European countries and in the United States, that often doesn't happen. So I think this is a move to try and encourage that. But I'm sure afterwards we can have a debate about whether this is a good thing or not. Now, we're all confused as to which classification to use. And at the moment, the British Society of Haematology has told us we should continue using the old WHO classification until heads are knocked together and some sort of consensus emerges. But I thought you'd be interested in those changes. So let's go on in the second half of the talk to talk about how MDS, and particularly low-risk MDS, affects people. So as I said, the dysplasia is a manifestation of ineffective blood cell production. And as I teach the medical students, if you have ineffective blood cell production, you tend to have low blood counts. By far the commonest low blood count are low red cells, and red cells carry the very important protein that carries oxygen around the body called hemoglobin. And we measure the hemoglobin. So your doctors will talk to you about having a low hemoglobin rather than a low red cell count. Because anemia is defined as a low hemoglobin concentration. And at least half of patients with MDS will have a hemoglobin of less than 10 grams per deciliter. 100 grams per litre in new money, I'm sure is what your laboratory tells you. And a normal 70-year-old would have a hemoglobin of around about 135 to 140 grams per litre. So this is quite a drop. And 80% of patients will require transfusion at some point in their journey with MDS. About a third of patients have low neutrophil count, and we call that neutropenia. And where you cut off the neutrophil count to call it neutropenia is also controversial. Here, they're saying less than 1.5, which is less than the normal range. In my laboratory, the normal range for neutrophils is 1.5 to 4. But again, as many of you will know, low neutrophil counts are not often a problem until they get very low, kind of below 0.5. And then the least common low blood count is low platelets, called thrombocytopenia. And about 15% of patients have a platelet count below 50. But again, there's a lot of what we call redundancy in the system, i.e. you have more neutrophils and more platelets than you actually need, which is a good thing. And so low platelets often don't cause the problem of bleeding until the platelet count is maybe less than 20. And we've talked about the overall risk to progressing to AML. This is a busy slide. I apologize for this, but we'll just cover a couple of little things in a little bit more detail. So as we've said, about 50% of patients will have a hemoglobin of less than 100. There's much discussion about what the trigger should be for treating anemia in low-risk MDS, either with blood transfusion or with some other of the treatments that we'll come on to. The truth is there isn't an absolute trigger, and neither really should there be. But because healthcare systems have to have structure, and day units that transfuse patients or community hospitals that transfuse patients have to have a kind of structure. And so triggers are often used. And, you know, you might be told by your doctors, oh, you don't need a transfusion because your hemoglobin's over 80, for example, or over 8 grams per deciliter, 80 grams per litre. But that's no good if at 80 you're on your hands and knees and you know can't climb up the stairs. So in good MDS practice, patients are transfused or treated when they need it. And there's a lot of interesting research in anemia, in MDS and other chronic anemias now. There's a colleague called Simon Stanworth who works in Oxford, who's a great leader in this area and continues to do important studies. Anemia is important because people who are anemic have poor quality of life, and elderly people who have anemia have a higher incidence of falls. It can make the impairment of cognitive ability, thinking ability that occurs to us all to some degree in older age worse, and it impairs health-related quality of life, and that's been shown. Probably also increases cardiovascular disease, so heart disease and the risk of stroke. And indeed, in the EU MDS study that I spoke about a few minutes ago, if you were anemic and had to have transfusions for anemia, you were more likely to have cardiovascular disease. And what the EU MDS has sort of led the charge on over the last few years is identifying these issues in patients with low risk MDS and trying to improve the lot of patients who are anemic. So they've shown without doubt that if your hemoglobin is less than 100 grams per litre, you have reduced quality of life, and they've done that in formal quality of life scores. And that if you're so anemic that you have to have red cell transfusion dependency, then that clearly has a significant impact on your quality of life and your ability to self-care. And that's highlighted the importance of trying to delay red cell transfusion and keep the hemoglobin high for as long as possible. So how do we manage MDS patients with anemia? Well, this has changed a little bit. This is kind of the up-to-date situation worldwide, though some of this is perhaps not available in the UK. So in blue, or in dark blue, is what we would commonly look for, and obviously top of the list is transfusion. And at the end of the day, transfusion is a bit like the Bank of England. It's the treatment of last resort. But it is a very, very important treatment because if nothing else can improve the dysplastic bone marrow, then red cell transfusion is essential. But those of you who receive transfusion will appreciate that it's a double-edged sword. It makes you feel better, but it makes you feel better for only a period of time, and then as you come up to the next transfusion you start to feel worse again. So the benefit is up and down, and it would be much better if the benefit was constant. And as many of you will know, red cell transfusions come with iron, and human beings don't have a mechanism for getting rid of iron. So if you transfuse, you start to accumulate iron. And that eventually can cause damage to other organs like the liver and the heart. Though I have to say, you have to be going it some to get damage. I wouldn't be overly worried about your ferritin level if you know what it is and it's higher than perhaps you think it should be. Lots of studies have shown that you have to get to very high iron levels before it starts impinging on function. But it might have more subtle effects, like increasing your risk of infection. And there's some quite nice data on that. So some patients, following a discussion with your consultant, will take iron chelation to try and, so drugs that bind the iron and allow it to be excreted in the urine, and therefore reduce the amount of iron that you accumulate. And I have lots of patients on that, and it is very successful. And of course, now we have XJade, which is an oral iron chelator, and that is preferable to the old-fashioned infused iron chelator, even though the infused iron chelator is very good. I mean, in Scotland, the rules of the game are that you're supposed to fail the infused iron chelator, Desferal, before you're allowed to have XJ, but the administration have had to wave the white flag because there aren't enough pumps, certainly in our centre, to deliver infusional deaths for our. So we've been allowed to treat everybody with XJ, which is very good. Now, whether or not you get iron chelation is a complicated decision. Iron chelation is a long-term treatment, so it's suited to people with low-risk MDS whose prognosis is good and are likely to be on transfusions for a long time. Now, the major non-transfusion treatment remains erythropoietin. ESA stands for erythropoiesis stimulating agents and is the umbrella term for these drugs because there's more than one type of erythropoietin now. So some of you may receive erythropoietin and some of you may receive darbepoetin, which the renal doctors use very widely for people with kidney failure. Erythropoietin, as you know, is produced by the kidney and it's a major regulator of red cell production from the bone marrow. And the reason for using erythropoietin is that many years ago, it was shown that some patients with anemia and MDS had a relatively low erythropoietin level, a sort of inappropriately low erythropoietin level. And I was lucky enough to be involved in the very first trial of using erythropoietin back in 1990 with Professor David Bowen and the late Professor Alan Jacobs in Cardiff. And we gave erythropoietin to 10 MDS patients, low-risk MDS patients, and 2 of them had a very good response, so 20%. And we now know how to identify, in those days we just gave it to anemic MDS patients, but now we know how to choose people who are more likely to respond to it. So if your own erythropoietin level is low, or if you're already needing a lot of red cell transfusion, then it's not likely to work. Whereas if you haven't had transfusion and your own erythropoietin level is low, sorry, I said low, if your own erythropoietin level is high, it's not likely to work. If your own erythropoietin level is low and you've not required transfusion, then it's likely to work. And about 3/4 of people with low-risk MDS are likely to get some response to erythropoietin if you choose them appropriately. And then you stay on erythropoietin until it stops working. And on average, it works for about 2 years in people who get a good response. And then the question is, what happens if erythropoietin stops working? Well, you can go on to red cell transfusion at that point. You can go back to the other arrow. Or, of course, the thing that excited us all were these ligand traps, of which luspatercept is the most advanced in MDS. And some of you will know that luspatercept went through a big worldwide trial for patients in whom erythropoietin had stopped working. And it was shown to improve the hemoglobin and prevent transfusions in about 1/3 of patients. And it has a license in America and Europe for patients with MDS and ring sideroblasts who failed erythropoietin. But for complicated reasons, it's never become available in the UK. And despite very tremendous efforts by the UK MDS patient group, we're still not in a position to be able to use luspatercept. And I think that still applies in England as well. Certainly in Scotland, we can't use it. And then there are rare other situations. I put azacitidine on there. There'll be lots of you thinking, why is he talking about azacitidine for low-risk MDS? Well, azacitidine is used in the United States for low-risk MDS. They don't distinguish between low-risk and high-risk MDS with the use of azacitidine, whereas in the UK, it's a drug that is available for high-risk MDS. And the drug lenalidomide that some of you will have heard of is a sort of new version of thalidomide, a drug with that terrible reputation. This is a very powerful drug in a number of situations in hematology, particularly in the disease myeloma, but it works very well in patients with MDS and 5q minus that we talked about earlier, who similarly have failed erythropoietin. So there are a number of treatments, but the main treatments are erythropoietin and transfusion. Immunosuppression with ATG is a very rarely used treatment for a select small group of patients with MDS where the cell count is relatively low. so-called hypocellular MDS. These patients are usually younger, but I only use this once every couple of years, probably. So when should you treat anemia? Well, I think the EU MDS study has identified you should treat it if you're symptomatic, and it's better early in the disease course rather than later. So I certainly don't leave patients to end up being transfused several times before I use erythropoietin. If somebody's got a hemoglobin of around about 100 grams per litre and are symptomatic, then I would start erythropoietin. It is a little bit controversial as to whether you should use it in patients with higher hemoglobin than 100, and those studies haven't been done. I do occasionally do that for people who have heart disease or lung disease or are really struggling with their anemia. But I think those studies need to be done. And the reason is of course, we don't like the hemoglobin to go too high because people then can have kind of sluggish blood flow and maybe at slight increased risk of having a heart attack or a stroke. Though I have to say that I've only ever seen a stroke once in somebody on erythropoietin in 30 years. But it does occur more commonly in diabetic patients who have kidney disease who are on erythropoietin with the kidney doctors. And I think the extrapolation from that has led to the caution. So in our guideline, we recommend the hemoglobin is not allowed to go much above 120. So if you start at 110, you don't have an awful lot of leeway to make much of a difference. We talked about the EU MDS, so it's a prospective 6-monthly register, and it's been going since 2007. There are several thousand low-risk MDS patients in the cohort. It is prospective, it's looking forward, not looking back, which is always the best type of study. And what they showed, they've produced many publications now, and I just highlight this one, which is I think very important. It was published in a very important journal, the Journal of Internal Medicine, and it showed that erythropoietin is more effective if used prior to transfusion dependency. So as I say, I don't allow patients to become very transfusion dependent before trying erythropoietin. And of course, one form of erythropoietin, now it took nearly 30 years, but EPREX, erythropoietin alpha, is now licensed in Europe for MDS. So some of you may be getting this form. We use a different form called neorecormin, and we use that because we'd been using it for a long time. The cost wasn't very different, so it would mean changing all of our protocols. So we kept going with neorecormin. But it's nice that there is a form of erythropoietin that is actually licensed for the use in MDS. Prior to this, there was no licensed drug. It just said for chronic anemia. So the conclusion for erythropoietin, which I think is the mainstay of treatment of the anemia in low-risk MDS still, is it's better to use it before people need red cell transfusion. If you do it that way, it can delay the need for transfusion, which is great from many points of view. And there are a little bit of data, particularly from the French, that if you respond to erythropoietin, you might live longer. But it's not. It's the random. There isn't randomized data for that really. Now, a little plug. So if erythropoietin stops working, the obvious treatment, if you're not a candidate for luspatercept and you can't get it at the moment, is red cell transfusion. So we're ever hopeful that we can find other treatments that might work. So in the UK, we've got this nice trial called Repair MDS. You may have seen it on the MDS patient website. It's been run by colleagues in Birmingham and Warwick. And more and more sites are open. So there's 11 sites open to recruitment. It's not a very easy trial to get into. I think we're all learning that. And it's using drugs that are commonly available, that there's some suggestion they might help the anemia in MDS. And so far, 15 patients have been registered and 9 have been allocated to the treatment. You have to be registered for quite a few weeks because the amount of red cells you're being transfused has to be measured before you can go into it. So it's for patients in whom erythropoietin has stopped working or never worked, and who now need red cell transfusions, to see if the need for transfusions can be halted for a while. So have a chat with your consultant about repair MDS. And then the final slides, and I've spoken far too long, neutropenia in MDS. So as we've said, the risk of infection increases when the neutrophil count gets less than 1. There are two things that really delineate your risk of infection with neutropenia, and that's how low the neutrophil count gets and how long your neutrophils are low for. So if your neutrophils are less than 0.5, and especially if they're less than 0.2, and that is on for longer than 7 days, then your risk of infection is quite high. Of course, these data predominantly come from people with leukemia and other blood cancers that get chemotherapy and whom their neutrophil count goes up and down and up and down. In MDS patients with neutropenia, it's often the neutrophil count is low continuously, and that's probably a different situation, and the risk may be less so in that situation. I have patients with hardly any neutrophils who never get infected. And we don't really understand why that is. So maybe there's a difference in the risk for people with acute neutropenia, i.e. it comes on suddenly and gets better after a week or so, like with acute leukemia treatment, versus chronic neutropenia, like some patients with MDS will have. There is guidance on how to manage neutropenia. So there's NICE guidance from 2012. And the there's the British Society of Haematology guidance from last year on MDS. There's a small section on neutropenia, and we recommend a short course of GCSF during infection. But we also recommend you can use prophylactic, that means giving it to prevent infection, GCSF, if people have had recurrent infections, i.e. they've had to come into hospital on more than one occasion. And if they're receiving treatment with drugs like azacitidine that makes the neutrophil count even lower. But that, of course, is for patients with high-risk MDS. And some of you may be on azacitidine for high-risk MDS. And similarly, you can use prophylactic antibiotics and antifungal drugs, but these, again, are better tested in high-risk MDS and AML. When I was the chairman of the clinical trials group, we tried desperately with a huge amount of work to do a trial called the Reprima study, which was to look exactly as to whether patients with MDS on azacitidine benefited or not from being on antibiotics and antifungal drugs. And we did eventually get approval by Bloodwise, as it was called then, but Blood Cancer UK, as it's called now. But it was just not long after the financial crises, and they ran out of money. So it never happened. And it's a shame it never happened, because there's a trial that has just finished that I won't mention because it's not published yet, that was done around the world in MDS patients. And there is some concern at looking at the data originally, the first look at the data, because there's a lot of very serious infections and quite a few patients were not on antibiotics. So that trial the trial that we were planning would have been a good one, but we don't have those data. So some of you might be taking antibiotics and antifungal drugs when you're having azacitidine, and some of you might not. We did do, when we were planning the trial, we did do a little survey of about 30 hospitals in England. And it was very mixed in terms. Some hospitals were using antibiotics prophylactically and some were not. And similarly with antifungal drugs, more were not using antifungal drugs than were using antifungal drugs, whereas with antibiotics it was the other way around, but it was very mixed. And then finally, managing low platelets. There's no uniform approach to platelet transfusions in MDS. A number of studies in blood cancers have shown the greatest risk of bleeding is if the platelets are less than 10, and many patients don't have platelets as low as that with MDS. And in my experience, people who do have platelets as low as that may have an immune reason for that. There's a well-known group of blood disorders called ITP, immune thrombocytopenic purpura, which are not cancers, they're immune attacks on the platelets. And some patients with MDS can get immune attacks on their blood cells, including the platelets. The recommendation is that if you're not bleeding and the thrombocytopenia is chronic, again, i.e. it goes on for a long time, as it does in MDS, then you shouldn't have routine platelet transfusions, because you might become immune to the platelet transfusions. You might develop antibodies to the platelet transfusions, so that if you need an operation or you have a serious bleed and need platelets, they might not work. So we try not to give chronic platelet transfusions, but some people have lots of bleeding, nose bleeding and gum bleeding and bruising, and they have to have platelets. So if you're in that category, don't worry. If you have to have them, you have to have them. But if you're not bleeding and your platelets are low, it's probably best not to have routine platelet transfusion. So I think that's by far enough. I hope you've found some of that useful. This is our fantastic new university library in Aberdeen University. And I'm happy to answer any questions or have a chat as people would like. Thank you.
Can I ask a question, Dominic?
Yes, of course.
Dominic, I'm actually in Sussex. I'm a long way from Scotland, but
okay.
And I'm newly diagnosed with MDS. But I guess, like all patients, I've been doing a lot of reading. But I find in America, for example, they publish a statistic that 40% diagnosis of MDS is wrong. And in Canada, they also say there's a higher percentage of misdiagnosis of MDS.
Yeah.
What do you think about this? With the analysis of bone marrow, I wouldn't have thought this was likely.
No, it's a very, very good question, Richard, and it is a problem, but hopefully it's going to become a bit less of a problem going forward. And the reason is that it comes back to this term dysplasia, which is a descriptive term, and bone marrows can show dysplasia in other situations. So, for example, if somebody has a cancer somewhere else, the bone marrow can respond to that, and the response is dysplastic, especially in older patients. If the bone marrow is stressed through bleeding, say through bleeding in the bowel, the bone marrow can look dysplastic. So, for example, I look after an elderly lady at the moment who has a condition that leads to regular bleeding of the bowel, a well-known condition, and from abnormal blood vessels in the stomach, and she has to have regular blood transfusion for that, and attempts from the gastroenterology colleagues, the bowel doctors, to diathermy these abnormal vessels. But she also has, when you look at her blood and her bone marrow, a lot of dysplasia. Now, that may be that the bone marrow is stressed at having to produce blood cells all the time to cope with the bleeding. And because it's an elderly bone marrow, it shows the dysplasia. So what I'm saying is dysplasia is not a diagnostic feature. It's a diagnostic feature if you've excluded all other causes for dysplasia. And increasingly, if there are other features of the malignant nature of MDS. So we call it clonality. It means that the bone marrow is malignant. And we identify that through chromosome abnormalities, cytogenetics, and increasingly through these abnormal genes that we talked about. And as we get more sophisticated in doing the genetic tests and we identify more and more genes, it's now recognized that if you look at all of the genes that have been linked to MDS, more than 90% of patients will have an abnormality in one of those genes. So we might get to the situation. So at the moment, there's maybe 10 or 15% of patients who don't have a genetic abnormality, and they're the more difficult ones. So historically, it may have been as high as 30 or 40% of patients were misdiagnosed with MDS, but that's becoming less and less because of the genetic diagnosis, though it takes a few weeks to get the genetic diagnosis. I hope that makes sense.
Hi, Dominic. Would you mind cutting your screen sharing now, and then we can see more faces?
Oh, yes. Yeah, sorry.
Right?
Yeah.
And I think Maureen's going to ask you a couple of questions that have come up in the chat box. So those of you who've got your hands up, we'll come to you in a minute, if that's okay. Maureen will ask the questions that have been put in the chat box first.
Yeah, okay.
Right. Well, thank you very much, Dominic, for our tour de force. I'm sure we're all a lot more informed than we were at the beginning, and it's great that it's being recorded and that you've produced so many slides for us, because I think it's the sort of topic that people will want to go back to and have a think about, and perhaps use some of the information that you've given in terms of informing their questioning, you know, when they're at their own haematology appointments. And I thought it was tremendous. So first, just a big thank you to start with. And just a wee aside, I'm an Aberdeen graduate and we're having our 50-year reunion in 2 years' time. So I hope I survive to see that beautiful library, because I believe that we'll get a tour of the new medical school, which was a new medical school when I joined it in 1968. So
well,
anyway,
the library is actually down at King's.
Right. Okay.
Down there, you'll see
I'll make sure I get there.
Yeah.
Anyway, sorry, I'll look at the chat now and we'll just go through the questions in order. The first one is, what about EPO if platelets 550 and hemoglobin 95? I think you covered that, didn't you? You said, well, sorry, I'll let you answer.
I don't worry about platelets being too high. I mean, some forms of MDS, like 5Q minus, and some other forms have high platelets. I think you have to be a little bit more careful about the risk of blood clots. So I would observe them. Something we didn't talk about today, which is very important, is the disorders that have features of MDS and myeloproliferative disease, the crossover syndromes or overlap syndromes, as they're called. They're very important. And they often have the difficult combination of anemia and high platelet count, or anemia and high white count. And providing the blasts are low, I do use erythropoietin there. In fact, I started a youngish man in his 50s with that last week. But we watch them a bit more carefully. So I think erythropoietin is appropriate in those patients. And indeed, MDS with 5Q minus classically has a normal or a high platelet count and an anemia, and the treatment of choice there is erythropoietin. So yeah, that's fine.
Thank you. The next one is, if GCSF is given in conjunction with EPO to boost response to the latter, would the GCSF normally be continued for the duration of the EPO treatment?
Yeah, that's a very good question. So historically, over the last 20 years or so, there's been a tendency and a recommendation that if you had sideroblastic anemia, then you got EPO and GCSF together. It was based on 1 or 2 trials. It was never really nailed down as being that important. So the current guideline recommends that you start with erythropoietin. Everybody starts with erythropoietin and goes up to the higher doses. But if they fail, you can add GCSF then. And if the combination works and improves the anemia, then the GCSF would continue. Often patients, in my experience, can have a relatively low dose of GCSF just to try and double the white count. And in fact, we here for a long time, what I've done is use the pediatric dose of GCSF, 105 micrograms 3 times a week. And that often is enough. But there's different regimens. But yes, if you're on GCSF and EPO and it's working, you will stay on both.
The next question is, so I have low risk MDS, EPO, GCSF and transfusions, then on Oxford trial, ASA and Magriolab, I don't know what that is, now due to go for transplant. How does this fit with your analysis?
Well, first, it's difficult with that because obviously a complicated case. I didn't talk about transplantation in low risk MDS because it's a very complicated area, but it's something that is being looked at worldwide. how do you identify patients? Traditionally, again, and in my practice, patients with low risk MDS are not sent for transplant. And the reason for that is that there are data suggesting that the risks of the transplant outweigh the benefit. However, there are some patients with low risk MDS that don't have as good a prognosis. So, for example, if you have things like very, very low platelet counts, if you're requiring a lot of red cell transfusion, or if there is fibrosis in the bone marrow. And these are all things that we are now looking at as possible indicators for earlier transplant in low risk MDS. And hopefully in the UK, there will be a trial. So my younger colleagues who are keen transplanters in London and Cardiff and elsewhere are working up a trial, though it will probably be a little while before it happens in exactly this. However, correct me if I'm wrong, but my understanding is that Paris VS's trial with magrolimab and azacitidine was for higher risk MDS. So the lower risk MDS may have become higher risk MDS for the trial. And therefore, at the moment, you're actually in a state of higher risk MDS, i.e. the disease.
No, it was originally done on high risk MDS, and then there was a second trial started on low risk MDS. Right.
Okay. My apologies. Okay. So it may well be that they think that your low risk MDS is of higher risk, if you see what I mean, maybe because of low blood counts. That would be the reason for it. So there are patients who have low risk MDS who are thought to need transplant.
Still had to be low risk to get on the trial. I had 2 months of what could have been a 4 or 6 month trial, and then they took me off the trial because it wasn't seeming to work.
Right.
And I became very neutrophilic, and was in hospital.
Right. Okay.
Times.
Oh, I'm sorry about that. But
but I've never had any of those other drugs or done the. But anyway, I'm going for transplant now, but I've never really
obviously the feeling, the doctor, I mean, it's difficult for me to comment on your case.
Sure.
But there's a fantastic team in Oxford, and I'm sure if they've decided you need a transplant, it's been very well thought through. So I wish you all the very best with that.
Okay.
Thank you. Another question about dental extractions and low platelets and low neutrophils, presumably about cover with
again, we get this question a lot. It depends on what the dentists are planning to do. If it's a straightforward extraction, and you're not somebody who tends to bleed very much, then a platelet count of about 30 is fine. We tend to say to the dentists about 50 if we can get away with it. However, if it's a more complex extraction, such as removing a bit of bone or a wisdom tooth or something, then we try definitely to have the platelet count over 50. And again, I think the neutrophil count depends a bit on whether you've had frequent infections and what level it's at. But if the neutrophil count is very low, you can do one of two things or both things. You could give a small 1 or 2 days or 3 days of GCSF beforehand, and the dentist will often give prophylactic antibiotics.
Thank you. Another one, this is interesting. How excited should we transfusion-dependent MDS patients be about lab-grown red cells being used?
I would be excited from the scientific point of view. I would be realistic and cautious about the ability to scale it up. That's been the problem. So there's been, Professor Mark Turner has been looking at artificial red cells in Edinburgh for many years, and they stopped doing it because even though they could produce the cells, they recognized they were never going to be able to produce them to scale that would allow them to be used clinically. So I think we're a long, long way away from that, unfortunately. It's an exciting idea. And in fact, it was talked about at the Scottish Haematology meeting again the weekend before last, and the ongoing problem of scale remains. So I wouldn't hold your breath.
Another question. I was diagnosed last year on EPO currently, but hemoglobin at 83. Consultant mentioned transfusions may be next step if my new increased dose of EPO doesn't work. How long and how often would one need to have blood transfusions for?
So what should happen is you should go up to the maximum dose of EPO, which in practice now tends to be 60,000 units of erythropoietin, or the equivalent dose of darbepoetin. We used to go up to 80,000 units, and I used to do that, but the present guideline that we've rewritten suggests there's no benefit for that. And you should probably have that for at least 8 weeks before you throw in the towel and say it's not working. But red cell transfusion is for as long as you can have red cell transfusion. So I have patients who've been on red cell transfusion for years. There are problems with it in that the longer you have red cell transfusions for, the less likely it is to work as well. And that's a complicated area as well that we don't fully understand, but may be related to your immune system destroying red cells. It's also related to the fact with the passage of time, the dysplasia gets worse, so you've less of your own red cells being produced. So those two things together mean that patients often require more frequent red cells with the passage of time. So I think sideroblastic anemia, in my experience, is the best example of that. So patients might be on once every 4 or 6 week transfusions, and after several years might be having it once every 2 weeks, and for some people once every week, because they just no longer get the benefit of it. But in conjunction with iron chelation, you can stay.
I'm a bit confused as to whether EPO only works for 2 years or the MDS progresses, so it's no use after 2 years. Could you be on it for years if it still works?
Absolutely, and I apologise for not making it clear. So you would stay on EPO for as long as it is working. And what the trials show is that on average, it works for about 2 years. So on average, if you take 100 people, we in medicine, we tend to use the median. So if you take 100 people who are all exactly the same and treat them with erythropoietin, after 2 years, 50 of them would have stopped working and 50 of them will still be working. And the reason it stops working almost certainly is that the MDS progresses and can no longer respond to the erythropoietin. But so no, there's no limit again. And I've got patients who are on it for much longer than 2 years, but on average, 2 years is about the time when you find it starts to stop working.
Right, thank you.
The thing that doctors always forget is that, and understandably, patients take dates and times very seriously. And the number of times that I've been told, you told me this would only work for 10 months. And I'm at 14 months and it's still working. I mean, we talk about averages, and the thing about prognosis and predictions, they're very good for groups of people. They're not very good for individuals. That's the problem.
I just wanted to add an anecdote to your last sort of question and answer, Dominic, because I was supporting somebody whose father had just been diagnosed and recommended to start having EPO. And I think the family were very frustrated because the father said he didn't want to do it. It's a bit like that thing about, not putting a cardigan on until it gets really cold because you won't feel the benefit.
Yeah.
And I think he felt that, he shouldn't go on the EPO too soon because it only had a limited life. And the sooner he went on to it, the sooner it would stop working. But, obviously from what you've said, it's very difficult to, make those sort of estimations. And it is actually better to go on sooner rather than wait till
it would be. All of the recent data suggests it's better to go on sooner rather than later. Yeah. But that tends to apply to people whose hemoglobin is less than 100. There is an issue with this sort of 100 level. And there needs to be more study on patients who are symptomatic of anemia but have a higher hemoglobin. That's an important area of unmet need and understanding. But yeah, sooner rather than later. And certainly the French have shown that starting within 6 months of diagnosis, if you're anemic, is better than beyond 6 months.
Thank you. And we have a comment here from somebody who's been on it for 3 years. So that's fine. Now, here's a long question. It's quite complicated. I'll just read it out as it is because it's beyond my comprehension. I have a question about the WHO ICC slide with the CCUS shown as I've been told I'm ICUS. Is this the same? And also I'm confused as I was told I was low risk MDS originally, and then was suddenly told I'm ICUS because of the bilineage dysplasia in the bone marrow not showing in the bloods when they came back, but I'm anemic and neutropenic.
Right, okay. So this is a very, very complicated area, and I didn't touch on it for that reason. So this all started, I'll go back to the beginning. This all started in 2014 when 2 research groups identified patients in the community who had normal blood tests. They didn't have any hematological disease, who had abnormal genes in their blood. The very abnormal genes that we've talked about that occur in MDS are present in normal people at lowish level. And this was called clonal hematopoiesis of undetermined significance, or CHIP. Okay, and what that meant is that there was abnormal genes in the blood cells of these people, but it hadn't led to a blood disorder. And we now recognize, there's been vast amounts of further work done on this, that this is a feature of human aging. So if you look at those who are lucky enough still to be under the age of 50, you don't see it very often. But once you get over 50, it starts to occur. And once you get over 80, in some studies, as many as 20% of people have clonal hematopoiesis. So there has to be a class, because this has been found now, there has to be a classification system for it. So if you just have the gene and your bloods are normal, as I say, you have something called CHIP, clonal hematopoiesis of indeterminate significance. And some patients may go on to get MDS, but nowhere near everybody. However, if you have a low blood count, but when the doctors look at your bone marrow, you don't have enough dysplasia to call it myelodysplasia, but the blood counts are low, you then have, and you have the genetic abnormality, you then have CCUS, clonal cytopenia of undetermined significance. So you've now got a low blood count, a cytopenia. You've also got the abnormal gene, which is the clonal bit, but your bone marrow doesn't show 10% dysplasia. And as you know, from all of the classifications, you need 10% dysplasia to have MDS. So that's another classification called CCUS. And in the new classifications, there are only the 2. There's clonal hematopoiesis of indeterminate prognosis if your blood counts are normal, and there's clonal cytopenia of undeterminate significance if your blood count is low, but you don't have enough dysplasia to call it MDS. Obviously, if your blood count's low and you have enough dysplasia, then you're called MDS. And the relationship between CCUS and MDS has still got to be further elucidated. I hope that makes sense. It's a very complicated.
I was just going to say, it sounds very complicated, so it's just as well it's on tape. People can go back and listen to it again later if necessary. Now, the next one is, have you heard of folic acid being prescribed for low risk? Any thoughts?
So folic acid can be used. Occasionally patients have low folic acid. What shouldn't happen is you're given long-term folic acid, because the reason folic acid is sometimes thought about, like B12, is that the anemia in myelodysplasia tends to have big red cells, macrocytosis. And people with B12 deficiency or folate deficiency also have macrocytic anemia. So it's coming back to what our colleague said at the beginning about misdiagnosis. So it's very important that you exclude B12 and folate deficiency before you make a diagnosis of MDS. So some patients might, if there's a borderline folic acid at the diagnosis, some patients might be put on folate to make sure that's not querying the pitch, as it were. And similarly, a lot of patients are found to have a borderline low B12, which is interesting, at the same time as they're diagnosed with MDS. And we would give them B12 replacement.
Then there's two, a question and a response to luspatercept. Can we do anything more to lobby NHS/government for luspatercept? And Claudia's responded saying lack of luspatercept. Oh God. Anyway, you know what I mean. Access isn't anything to do with the government or NICE. It's pharmaceutical company not going ahead in the UK.
Correct.
I don't know whether you have anything to add to that.
No, that's absolutely Claudia's absolutely right. That's the problem. I suppose this does occasionally come up with other drugs in that companies decide not to market them because they think the drug's not going to be used, or it might not get through NICE or SMC. It's a complicated thing. I certainly have not been involved. I was involved in azacitidine a lot, but I've not been involved in luspatercept, but I know other colleagues have been, and I know Claudia and Sophie have been involved in it. And I think as Claudia says, everything has been done that can be done.
Thank you very much. We've gone through everything that's in the chat, and although people can continue to put their questions in there, there were some questions put in by people at the time of the registration, which might be of interest. One is, what is the commonest non-genetic cause of MDS? And a supplementary thing, can COVID trigger the condition?
So I'll start with the second first. So there's no data that I'm aware of that COVID triggers MDS or any other cancer. Okay, so that's the first thing. The second thing, it's a very good question. I don't think, I think maybe I would change the question a bit. I suppose it's what is the cause of genetic MDS, and that's been looked at for many years. When I was a young doctor in London, in Cardiff, there were a lot of what we call case control studies, where very nice studies where people with MDS had their employment and their life looked at, and it was compared to age-matched people who didn't have MDS. And it found that a number of professions and a number of exposures seem to be increase your risk of getting MDS. So those studies have been done, but they work. If near enough all of the triggers, whatever the triggers are, I mean, most people, we don't know what the triggers are, work through altering the genes. So I don't think you should talk about non-genetic MDS. I suspect we'll find out that all MDS is genetic in the fact that it's caused by damage to genes in the bone marrow. There is another thing which is very interesting, though, is that the actual manifestation of the MDS may occur because of the way the damaged stem cells interact with the rest of the bone marrow. And there's a lot of interest in that, especially in leading to inflammation, chronic inflammation in the bone marrow. And there's an awful lot of interest in that. So that there might be an inflammatory response to the damaged stem cells, and it's that inflammatory response that then leads to the low blood counts. So that's also very interesting.
Thank you. Another question submitted earlier: have there been any real advances in treatment of MDS?
I think that's a really good question. I think there have been. I think allogeneic stem cell transplant is a very important treatment and a successful treatment for the relatively small proportion of MDS patients for whom it is appropriate. Maybe about 20% of MDS patients. I think that you can't. It is a tremendous treatment when it works. Is allogeneic transplantation. Azacitidine was undoubtedly a development. It maybe wasn't as great a development as people hoped when it first came out 12 years ago. I think the great hope, and we await the Verona trial, is that the addition of the drug venetoclax to azacitidine is going to be the next big step. It has proved to be an impressive treatment in older patients with acute myeloid leukemia, and has become the standard of care in older patients with acute myeloid leukemia as azacitidine and venetoclax over the last 2 years. The Verona trial has looked at the exact same treatment in MDS patients, and we await the results of that. So that may be the next big development. There are lots of other clinical trials, but at the moment, that in the recent past, that's where the developments have been. Lenalidomide in 5q- was also a development, an important development, but relatively small numbers of patients, of course, very select group of patients. And supportive care is very important in all these diseases. So XJ, the iron chelator we've talked about, was important, and erythropoietin. But that's about it at the moment. So what we're all waiting for is azacitidine and venetoclax, and there should be data on that next year. There are a number of new treatments in development that possibly will help with anemia, and as is often the case, they're being trialed in different types of anemia like thalassemia, but as was luspatercept. But the hope is that some of them will also benefit patients with MDS, but they're some way off at the moment. So look out for azacitidine and venetoclax.
Because I was going through sorting out my things today, and I saw this, and it really made me think about MDS. Let's see if I've got it. Let's see. Can everyone see this cartoon?
Yep.
Yes. Yeah.
Doesn't that say it all about MDS? You know, I mean, I've spent years going you know, and when you get drugs like luspatercept and macrolidine and whatever, you feel like you've lost the power of speech. Anyway, I thought I'd just share that.
Yes.
What if you've got MDS and low platelets, and you also have atrial fibrillation? What are the risks of using the newer anticoagulants or any anticoagulant therapy in that situation?
Yeah, so that's a great question, and it's a challenge we see across the range of blood disorders. So people who have a risk of bleeding, but also need to take drugs that will make the risk greater. So as you know, your doctor will recommend that you have anticoagulation for atrial fibrillation if you have a certain score, this CHADS-VAS score, which as we all get older, we're more likely to you know have a score of 1 or 2 and or higher. So need anticoagulation. So again, it depends on what your platelet count is. So if your platelet count's over 50, it's fine. That's what we go for. And of course, if you have something like apixaban, you can have a relatively small dose. So some of the new anticoagulants have different dosage levels. Apixaban's one of them. You have a 2.5 milligram dose of apixaban. If the platelet count is less than 25, it's considered hazardous. And then in the range between 25 and 50, then the perceived wisdom is to give platelets to keep the platelet count up and give the anticoagulation. Now that works better for people who need anticoagulation for a short period of time. For example, if you've had a blood clot and need it for 6 months. But if you're somebody who's going to need it for years for atrial fibrillation, that's more of a challenge. So it's, you know, you've got to talk about the balance of risks with your doctor. Really. So if you have a platelet count of 15 or 20, then anticoagulation may be hazardous over the long term, and it may be that you decide to take your chance with the atrial fibrillation without anticoagulation. Again, it depends on how many risk factors you've got. If your risk factors mainly the fact of your age, but everything else is pretty good, then that might be a risk worth taking. But it is something that has to be done on a case-by-case basis. But if your platelet count's over 50, I think you're safe, you're fine.
Thank you.
I see that Mike Maud and Derek Bott also have hands up. So could we start perhaps with Mike and then have Derek's question, please?
Hello, Dominic, and thank you very much for that incredibly interesting talk. My question is really about whether you see stem cell transplant as becoming more mainstream in terms of low-risk treatment. I'm asking because of my own experiences. I'm 73 days post-transplant. I've never been considered as anything other than low risk. I didn't realize that was outside of the mainstream. I may be misrepresenting you, but you said it was done by certain younger doctors in certain centres. I've become a bit evangelical about it because it was a terrifying prospect, but it's been the actual experience has been much less grueling than I was expecting. So I wonder if you see this, presumably as transplant success rates improve, whether you see this as being offered to more low-risk patients.
Yeah, no, absolutely. It's a very good question. I'll just clarify, I obviously didn't make myself clear enough. The clinical trial that is being planned is being led by a group of younger consultants, as these things should be. But no, low risk MDS, certain patients with low risk MDS definitely would benefit from allograft. It's not that well defined. And there's been a lot of confusing information in the past, confusing for MDS specialists, because there was a very important study from the United States that suggested that patients who had low risk MDS as per the IPSS score or intermediate 1 as per the IPSS were harmed more by transplant than benefited, and that you should wait until the disease had progressed. Now that was a controversial statement, but it coloured a lot of doctors' thinking for quite a long time. So sorry, I've logged my machine's logged me out because I didn't do anything with it. Hang on. Can you still hear me? Yeah.
Yeah.
So what I think what the whole MDS community is trying to look at now is, can we identify patients with low risk MDS who really do benefit from transplant earlier on? And as I said, the things that might be important are people who have low platelet count, people who are requiring a lot of red cell transfusion, and people who have certain of these abnormal genes, because certain genes, even though the disease is otherwise low risk, may not be low risk. So the term is that as complicated, as confusing as it is, how can we identify the high risk, low risk patients, if you see what I mean? And it may well be that your team had identified you as a high risk, low risk patient, and that transplant was the right thing. Do you mind if I ask, were you requiring a lot of red cell transfusions before the transplant? Or?
I went through a route of EPO, which lasted a couple of years, a trial on lenalidomide, which wasn't successful, occasional transfusions, and then very quickly, once I started transfusions, went from occasional to requiring 3 units every couple of weeks. And it was, so yes, that seemed to happen not over years, but over months in my case. But I very much felt I was offered this opportunity. I could have said yes or no, I guess, but the idea of just logistically that transfusions was becoming really, really complex for me.
Sure. And you're a very good example, exactly what we're looking at in low risk populations is how do you identify people who it's worth taking on the risk of transplant? And I'm absolutely thrilled that it's gone well for you, because that's brilliant. But it is it's a brave thing to have done, and I'm sure they I'm sure you were put through the ringer in terms of the information you were given before it.
Right.
Absolutely. Yeah.
Thank you.
Absolutely.
Oh.
Sorry.
I'm just aware that Dominic has another meeting in less than 10 minutes. Yeah. So do you have time for 2 or 3 final questions, please? I don't know how far you've got to run to get to your next meeting, but Derek, you had your hand up. Are you there? Oh, yes.
Yes. Well, first of all, in common with everybody else, it's been an absolutely brilliant description of MDS and various sides. And the question that I have is, I'm on, amongst other things, the antifungal antibiotic and GCSF prophylactics side. And my question is there a point at which the effectiveness of GCSF falls away?
Not obviously. I think where it would fall away is if the disease progressed towards leukemia, and then it's unlikely to have any benefit then. But if the disease is stable and the neutrophil count is responding to GCSF, then again you can go on with it for long periods of time. Yeah. Is that being used with azacitidine or just on its own?
No, just on its own, being neutropenic only, and under the guise of your a colleague of yours previously, Dr. Sardi, at the Borders General Hospital.
No, it's absolutely. And has it reduced your risk of getting infections? Has it been good?
Yes, it has. I mean, last year I had 2 hospital admissions for neutropenic sepsis, and I've had none this year. So I'm really grateful.
Fantastic. Yeah.
And I think that's really very helpful indeed from what you've said. And thank you very much again.
Yeah. Thank you.
Okay, two very quick, I hope, final questions. Hello, can a high ferritin count 984 but normal iron profile cause MDS or affect it?
No, so high ferritin doesn't cause MDS, though it does. There are some fascinating studies and cases, I've seen them, of people who have MDS and a high ferritin, in whom the hemoglobin gets better when you bring the ferritin down. And they've been those cases, they're rare, but they've been described in several studies over many years. So it may be that high ferritins in some way contribute to the ineffective erythropoiesis, but there's no evidence that they cause MDS. So the best explanation for that is that there are patients with a genetic disorder called hemochromatosis, one of, if not the commonest inherited genetic abnormality in the Western world and the Northern Hemisphere. And these patients accumulate iron from an early age, from early adulthood, and there's no evidence that they're more likely to get MDS than anybody else. So there is this, and how and why people accumulate iron and have a high ferritin is also fascinating. It's mainly to do with red cell transfusion, but people who have ineffective red cell production tend to accumulate more iron also. And the EU MDS registry has shown that in some very nice studies. Excuse me.
Thank you very much. Well, before you lose your voice, is there anything we can do as a support group to encourage clinicians to follow BSH guidelines and use symptoms rather than HB levels to be the trigger for a transfusion?
No, I think
from an aggrieved transfusion-dependent patient.
I think to be fair, most hematologists would want to do that. I think where the problems come is in the logistics of setting it up, because if you have people who if you have patients who need regular transfusion, as many patients do, the hemoglobin varies a bit, and the decision making is often passed down the line to a clinical nurse specialist or a junior doctor, and they have to have something to hang their hat on, and they often hang their hat on whether the hemoglobin of 80 has been breached or not. But I would hope that the majority of right-minded haematologists will set up transfusion based on symptoms and regularly assess patients as to how well they're doing on it. That's what I tend to do, and I think most people do. Though again, it was discussed at the Scottish Haematology Society meeting 2 weeks ago with Simon Stanworth about how we move away from triggers and to symptoms and different ways of transfusing patients. So, we did this REDS study with Simon, and we took part in it and put 4 or 5 patients into it from here, and it was comparing people having a low trigger to a high trigger, and the people who had a high trigger had much better quality of life, but they used a lot more red cell resource. And that's the other side of the equation. You'll have heard on the news, both in England and recently in Scotland, there's been a shortage of red cells. And sometimes that has to be taken into the equation as well. All of these things, day unit capacity, organization of regular transfusions, utilization of blood, all of these things come in to conspire against people getting transfusions because of symptoms. Simon Stanworth is doing a REDS 2 study now in just a couple of centres, Newcastle and Oxford, I think, where they're looking at this business of giving 1 unit a week without, and maybe that's a better way of doing it. But there's lots of different approaches being looked at for transfusion.
Right, I'm very conscious of your time. I would like very cheekily to ask a question myself, if that's okay. I just wonder about there seem to be it's about lenalidomide and ancillary treatments to go with it. And there seem to be different protocols in different hospitals. And I just wondered what your view on concomitant antivirals and antibiotics in conjunction with lenalidomide.
Well, I can tell you what we do. So patients who are on lenalidomide, patients on lenalidomide in myeloma and with MDS, if the blood counts can tolerate it, we give them Septrin prophylaxis. And the reason for that is that we did an audit some years ago, one of our registrars, and we saw quite a bit of pneumocystis infection in patients on lenalidomide. So we do that. Patients with myeloma, we give acyclovir to, because patients with lymphoid malignancy are prone to that. Patients with MDS, we don't routinely give acyclovir to unless they've had shingles before. But we tend to give pneumocystis prophylaxis with lenalidomide, rightly or wrongly, unless the blood counts. And the trouble with Septrin is it can lower the blood counts. So the blood counts have got to be able to tolerate it.
Right, I didn't know that. Well, thank you very, very much. You've given us such a fantastic lecture, so many questions. There's been lots of nice comments in the chat from people who had to leave early, which you may not have come across. But I'm sure that everybody would want to join me in thanking you for your time and your very good, very comprehensive presentation. And maybe we'll have you back. It obviously draws people in. So thanks very much. And
I hope people have enjoyed it and got something out of it. And I apologise for the times when I've not been as clear as I could have been, but hopefully overall it was okay.